I switch. Yeah. Don't take it personal. All right, let's call this meeting to order. All right, we call this meeting to order. We're going to take roll call to quorum. Looks like we do that. No quorum, none of those. All right, no quorum, so we'll hold off on the minutes for now. First presentation on the agenda today is from Ben Beeks, representative West Virginia Health Plans, Executive Director, discussion of Senate Bill 419, establishment of pilot project evaluating impact of certain controlled substance use disorders, residential treatments. Ben, welcome. Who's going to raise your right hand for us? We swear that your testimony to the truth, the whole truth, nothing but the truth.
I do.
Okay, well, thanks for being here, Ben. Go ahead and get the floor.
Thank you, committee, for coming to Wheeling and here at the health plan, one of the members of the West Virginia Association of Health Plans. For those that don't know me, my name is Ben Beeks, and I am the executive director of the West Virginia Association of Health Plans. You can see our three members here, Aetna, the health plan, and Unicare. So let me, before we get into it, just real quick, give you a quick rundown of who the association is and what we do. We'll get into the meat of our talk. Right now, like I said, the three members, Aetna, the health plan, and Unicare, managed care companies. We serve about 450,000 West Virginia Medicaid members as of the latest report. There are nearly 600,000 total members in Medicaid in West Virginia, so 450,000 of them are in the managed care plan. So what is managed care? We don't just pay bills. We employ about 400 to 500 professionals, including care managers, who help Medicaid members navigate the healthcare system and ensure members are receiving the medically necessary services and care that they deserve. Many times, our roles extend beyond just traditional medical services and trying to help navigate for Medicaid members. For instance, they don't have transportation to get to a doctor's appointment. Our care managers, help make those arrangements for them. We do this through vast community partnerships, in addition to our vast network of providers, healthcare providers. So that's what managed care does. Happy to talk to you about more on managed care and the model at a later time. There are some services that are handled by the state. We call that fee for service, that are not in managed care. So the state contracts with the three plans currently to help manage the bigger portion of the Medicaid program. But there are some services like pharmacy benefits, we don't handle those. Long-term care, so the nursing homes and things of that nature, we don't handle that benefit. Or IDD waiver or things of that nature, the state takes care of most of that. So before I get into it, just a couple of ground rules so that you all understand who I am and what my expertise are. I am not a medical professional. Okay, so I don't want anybody to think that that's the point of view that we're coming from today. Have played a role in this process with this project specifically just as a facilitator and a consensus builder. And so today I'm here playing the role as communicator with you. So what we're working on was a bill that was passed Charlie, how do I advance the, scroll down? Okay, gotcha. Senate Bill 419 was passed during the 2022 regular legislative session. Senator Weld was our lead sponsor on that bill. We worked a lot with him on this and have since then. So the concept of the bill was something that the Association of Health Plans fully supported. Essentially, the purpose was to recognize there's been a proliferation of substance use treatment services in response to the opioid epidemic and the need to explore different models for paying for those services. Essentially, Senate Bill 419 attempted to establish a structure by which payment was tied to performance by the healthcare provider. So we're not the healthcare provider, we're the payer, okay? So the MCO, in the MCO world, what we call these types of contracts are performance-based or value-based contracting. So if you hear me talk about that, I just want you to know what that is. And during 2022, stakeholders met to explore implementation strategies. And those efforts culminated with an April 2023 interim session meeting of this committee, where the Bureau for Medical Services and their commissioner, Cindy Bean, presented to you all, hey, we had some difficulties implementing the stakeholder group that they had assembled, some of the provisions of this bill, and there was general discussion of how do we move forward. So after that meeting, the Association of Health Plans and our members raised their hands and just says, hey, can we just take a shot at it? We just like some time to maybe talk amongst ourselves internally and our professionals, what we're seeing, and maybe suggest back to the legislature, maybe here's some other ways that we can look about implementing the model that Senate Bill 419 proposes. And so that's what I'm here today to kind of present to you. So first, you know, the little timeline of the substance use disorder. Specifically, we're talking about residential substance use disorder treatment. So in 2017, the legislature was very clear. It supported efforts to increase the access to substance use beds. So here's a little chart just so you can see. July of 2019, we had 648 licensed Medicaid residential treatment beds in the state of West Virginia. Today, we have 1,610. So this is a big jump in a very short period of time. In July of 2019, the reason that date's up there, the sub benefit was shifted from a fee for service, meaning just managed by the state, to the managed care organizations to help bring, management of the treatment and get a handle on kind of data, tracking and things of that nature. In July 1 of 2022, though, was another big change. And up until that point, basically any residential treatment facility that was licensed, we were mandated by the state that we had to contract with. And this was just a policy decision that we need to increase access to beds. We're going to do everything we can. But on that date, July 2022, that's when the state told us, okay, now just like all the other services, you all now have the authority to start contracting with the ones that you deem appropriate. We still have to meet network adequacy standards, meaning adequate coverage throughout the state, but that was a change. And since that date, there have been a couple of providers that the managed care companies felt did not need to be part of the network anymore due to various reasons, and their contract was not renewed. So that's in 2023. Obviously, this past legislative session, that there were some limitations and requirements placed on substance use disorder residential treatment facilities. The reason I'm kind of taking you through the timeline is it just kind of shows how the policy objectives of the legislature and of implementers like DHHR have looked at this. We went from, we got to do everything we possibly can to open up as much access as we can, to now we're looking more at, we need to be focused more on the quality part of this, not necessarily total access. And that's where the Senate Bill 419 began to come into play. I'm not going to get into the details of this, but you have a white paper that we published and sent to the committees. that was completed on August 31st of this year that goes into the details of this. But since the managed care companies have managed the benefits, we have worked hard on trying to improve some of the quality measures. These are what's called HEDIS measures. These are national standards done by NCQA, the National Committee on Quality Assurance. So we can measure ourselves, the MCOs, versus other MCOs across the country. There's a few of these measures that you'll see. We've obviously had a lot of increase since we've managed the benefit over time. But there's a few of these measures, and it's outlined in the white paper, where we are in the 95th percentile in the country. So these are things that we're proud of, obviously, but we also know that West Virginia was hit probably the hardest of the opioids. So we have a long way still to go. By no means is this done. So those are just wanted to give you a kind of a glimpse of some of the work that we're currently working on. So what did Senate Bill 419 do? Now, I'm not going to go through all of these. Again, we supported a lot of these. These are measures, performance measures that the provider community would be responsible for. And these measures would be tied to their performance-based payments. So instead of paying for just a service, somebody was in a bed for so many days getting treatment. The policy that Senate Bill 419 contemplates is, let's start looking at how do we pay for the performance measures, for outcomes. And so here are some of the measures. These are the measures that were outlined in that in Senate Bill 419. So it wasn't necessarily incumbent upon the MCOs. These were measures that providers needed to meet. And our objective was, we need to find providers that would be willing to take a contract based off of these performance measures. The challenge, though, was we did look to implement this. The MCOs had a survey that we generally reached out to various provider communities and says, okay, here are the provisions of Senate Bill 419. This was a voluntary program. It was a pilot program. Can we get anybody, that was our task, to abide by and agree to the provisions outlined in 419? The answer to that question was no. We didn't. The provider community, through a task force that the Bureau for Medical Services had established, expressed several barriers to being able to implement what was in 419. So here are some, this is the MCO's thoughts on why there were challenges to implementation. That's what's on your screen now. This is outlined in your white paper. So the first is, providers were not required to participate. So this was a voluntary program. So there was no compelling reason for providers to want to or have to participate in the performance measures outlined in Senate Bill 419. The next one, our case managers, our care managers, our job is to make sure we understand where are our Medicaid members in the healthcare process. How do we help them navigate that? How do we help ensure that they're getting the services that they need? Our access to our members in the facilities varied widely amongst providers. It was not uncommon for us to not even know one of our members was in treatment until after they had been discharged when we got a claim. So a perfect scenario would be our case manager, we would know the day that they're admitted. We would be meeting with that facility, with the provider, working on discharge planning from day one. Fortunately, for a large portion of the providers, we were just outright denied access to those facilities. Now, some of the worst ones obviously don't have a contract anymore, but this continues to be a bit of a problem. Third, and some providers are great. I do not want to use a broad brush. Some are wonderful and great partners, others not. This was an unintended consequence that we didn't even think about during the talk and when we were putting this together. But we all know, and you all have heard testimony this year, there are certain factors of members that come into treatment that lend itself to better success. Family support, resources, transportation, network of support. There are many factors that go into that. And so what we found is when discussing this with providers, we realized some of the hardest cases, the performance measures actually disincentivize providers from taking more risk. And so that was just an unintended consequence that we did not think about at the time when this legislation was being drafted. So again, I won't go through all of these. You can see some of them and they're outlined in your white paper there. Challenges that we felt hindered the ability to implement all the provisions. So at the end of the day, what we're here to discuss with you is the MCOs have made some recommendations. We're not advocating for these changes. We are simply here to be a resource to you. You're the policymakers. We want to implement policy. But we also want to be partners with you to share with you from our standpoint, in our seat, and our experience with this. These are things that we think might not be complete outcome measures at the end of the road, but they're input measures that we know for a fact lead to better success on the treatment scale. And so here are the 7 performance measures that we would recommend the legislature looks at and maybe retool Senate Bill 419. And you can see some of these. For instance, I've already spoken to this. Providers should execute adequate discharge planning and notification. That should happen day 1 upon admission. And so providers that do that should qualify for this incentive pay. 2, it gets to the assessing patients who come into treatment for and arranging for treatment for their behavioral health conditions that are comorbid with substance use disorder. Now, some of you that are familiar with Senate Bill 419 are going to say, Ben, these look kind of similar to what we were doing. And you're right, except it doesn't have the timelines associated with it. What we're focused on here is what can we control at the beginning of the treatment process, and can we tie the performance measures to those things? 3rd, providers must grant access to Medicaid-assisted treatment. That's actually a requirement of the contract, but it's not happening everywhere. Providers evaluate members for other health factors. And so part of the problem we see across the board in the managed care world is, yes, we're treating substance use disorder, but most of the patients have so many other health factors that are not being addressed while we have them in a captive audience in treatment. So that's a big one. 5, providers assess social determinants of health and help us with that. While we have these patients, because these are folks who are very transient, many of them have been court ordered to be in treatment. They don't want to be there, some of them. Many of them don't have family support structures. Many of them are being treated in a location miles away, hundreds of miles away from where they live. Reaching this group and keeping track of where they are and trying to help them is very, very difficult. So while we have them in treatment, these are things that we want to do, and I won't go through all the rest of them, except for providing access to the MCO care managers would be one of the things that we would want to measure and require out of the providers so that we can help the state better track the success rate of treatment. So with that, I will stop. Happy to answer any of your questions. Again, the position that we have in the association, much of the bill as contemplated, it was not a policy that was placed on the managed care companies. Hey, you need to do all these things. In fact, it was more on the provider community. But we just didn't feel right just to say, well, we couldn't do it and have all the stakeholders. What we wanted to do was say, well, let's at least go back and see what are things that we think we can do to maybe make this, to be able to implement. I think if we do this for a few years, we're going to get to a place where the original provisions of Senate Bill 419 become doable. But there are some basic things that are not happening currently that need to happen before we get there. That's our opinion. So I've shared this with the Behavioral Healthcare Providers Association. I shared it with both councils of the Senate and the House Health Committee. I had a discussion with the lead sponsor, Senator Well, a couple times about really just not seeking permission, but kind of letting you all know we're going to do this. We're going to kind of do a study of it and try to get back to you. We just wanted to make sure that there were at least enough partners who said, yeah, let's give it a shot and see what you come up with. And that's why we're here. We just want to be a resource to you. These are our recommendations. Happy to take any questions you have.
Ben, thank you for that. We're going to take some questions now. Ben, I'll start with the Senator from the first.
Thank you, Mr. Chairman. Ben, first, let me thank you this is very detailed, and I know this was a significant amount of work on behalf of the people that you represent. So thank you for
Yes, sir. Thank you
for doing this. It's very helpful. I had a couple of things that I wanted to, and I just want to learn more about. So, the first part outlines that the efforts to bring people in to participate in the program were unsuccessful at the outset, because it's not a mandatory piece of legislation. What were the reasons why people didn't opt in? Were they different than what is outlined and what you put together here, or is it part and parcel? I mean, what were some of those initial causes for concern that people said, we're not going to do this?
Sure. So I'll repeat a little bit of what the commissioner and her task force, of which we were one part of, stated back in April, but also in our conversations with the provider community. The analogy was used, and I hope I don't get this wrong, but essentially, are we tracking 3, 5, 10 years down the road of, forget about it, substance use, but of anybody that comes in and has any medical procedure in a hospital? We're not requiring that out of hospitals. Why would you require that out of treatment? That was one provider issue. But what was at the heart of that, if I understood them correctly, was, look, we have these folks, the residential treatment facilities, for a brief period of time. Our ability to track them down 3 years from now, very, very difficult for them to do, if possible at all. Now, can the managed care companies help with that? Absolutely. What we're saying is, if we can take care of some of the front end of these, I think we'll have much more ability to be able to find and determine how are they doing long term down the road. So that was probably the primary thing, is the difficulty from the providers. And I don't want to put words in their mouth, but from what I understand is they did not have the ability to track progress over a long period of time.
Okay. The next question. So on page 5, handouts here, says that you all would like to have in place a performance-based or value-based contracting approach. How do you all define that exactly?
In its most basic form, if you think about a medical procedure, and let's say you have a tonsillectomy, and an insurance company has a contracted, negotiated rate with a medical provider. Hey, for that service, we're going to pay you X number of dollars. Performance-based or value-based takes on a bit of a different twist. There's probably a portion, and most likely a portion of, you're going to still get paid for a service, just delivering a service. But above and beyond, if there are certain performance measures, certain things that you are doing that is enabling the better quality of care or the long-term success of that care, there are extra payments and incentive pay, for a lack of a better term, on top of that. So the managed care companies actually do this quite frequently across the spectrum with many different providers, especially when it comes to think about neonatal care, diabetes care, cardiovascular. So there are things that are incentives for certain provider groups where the MCOs are saying, look, we'd like to structure this different. Instead of just paying for a direct service, let's pay for a process that we know leads to better outcomes. And so that's where this is getting. And Senator, I think that's exactly what you were trying to get at with Senate Bill 419.
So how do we then determine which process leads to better outcomes like, how do we get to measuring that?
Yeah.
If,
Yeah, so where we are today is these 7, we feel, and the groups that participated and developed this were the medical directors of each of the MCOs, the substance use director coordinators of each of the MCOs, plus a myriad of support staff at each of the MCOs. That there were probably about 20, 25 people that participated in the inputs on this. And what we're saying is, we think if these are the measures, these are things that we would tie payment to. If providers are doing these things, that would be how we would structure our incentive pay based off of these 7 measures.
well, again, thank you for
Yes,
all the work that you guys did, and I certainly look forward to working with you between now and sessions during. So,
Certainly.
thank you. Thank you, Mr. Chairman.
We're gonna do a few more questions. We're gonna cut it down to about 5 more minutes with Mr. Beeks here, okay? So the co-chair has a question.
Thank you. Ben, this is one of the best papers I've seen in a long time, and coming to the session, I mean, like, it really takes a bill and helps figure out ways that we can do better. And I just want to say I really appreciate that. We, despite everything we're doing on substance use disorder in West Virginia, we're failing. I mean, we're having successes, but in general, overall, we're still having way too many people die. So we do have to start changing our focus, like you said, into making sure that our programs are providing quality care. So on the process part of it for the value-based, what you're saying is let the contract come up with what the processes are after you determine what you think are the best performance measures that are out there, and not put the process in state law, because processes will change as we learn better ways to do things. Am I understanding that correctly?
I would agree with you on that, Delegate Summers. And, Cindy Dellinger, the staff attorney for Senate Health, did unbelievable work in putting Senate Bill 419 together and trying to build consensus. Without this, we're not even here talking about a change in how we're looking at these services. So the sponsors of the bill, the legislature contemplating that. I mean, this is, I think, is a major step in the right direction. We do too. You're right. We have the ability to contract with substance use disorder facilities now. And we have the ability outside of that on any other medical service to do value-based contracting. And that's a negotiation between the provider and the insurance company, the managed care company. So yes, if the legislature were to want to say, look, we want to at least put something in stone to start with so that we know something's happening, these 7 are our recommendations. But you're right. At the end of the day, that becomes a negotiation between managed care company and the residential treatment facility. Did I answer your question?
Yeah,
Yes,
thank you.
thank you.
Any other questions? The last question, Rebecca. Oh,
Thank you, Mr. Chairman. Thank you, Ben, for being here. I have a question about recommendation number 6. And I know that we expanded access to the managed care coordinators for children that were involved in abuse and neglect situations to allow them to sit through NDTs. But we have not expanded that for adult individuals that are involved with an adult treatment court or a family treatment court. Is that correct?
I don't believe we have that benefit.
Okay.
We're not, that's not in, the adult is still fee for service.
So it also could be a possibility if we allow those individuals to participate in some of the MDT meetings with these adults that are involved and engaged in the court system, that it could be a potential benefit and facilitate coordination of care. Would that be an accurate assessment?
I think that's an accurate assessment. I mean, in the original bill, that was our one request in Senate Bill 419, by the way. And when Senator Weld assembled the stakeholders, we just said, hey, this team that you're assembling, the task force, we would just like a seat at the table for that. And the Senate Health Committee did make that amendment, which we're very appreciative of. At the end of the day, what we're really good at is being able to facilitate the care of our members. The more access we have to our members, and this is one of the most challenging populations, because a lot of these members are transient, because sometimes we don't know where they are. But when we do, that's the opportunity we have to go into action. And so, yes, anything that we can do to have access to our case managers, our care managers, to be able to talk to our members and help them and provide organized services for them is going to make the problem better.
that sometimes when you sit through those MDT treatments, and I've gone to my family treatment board several times to sit through things in my county, and it's just always, it's very insightful to listen to some of the pitfalls and challenges that people have to meet some of the goals. And so I think that might be a good way to facilitate care. I also think maybe coordination with the DHHR between the MCOs. Like I always hear a lot of complaints about mobile care, and as far as getting transportation for patients, I hear that they get scheduled and then they get canceled. It's not just the substance abuse population problem. It's all through DHHR and Medicaid patients that need transport for various types of appointments. So those are some issues I think we really probably need to work through and figure out how to best cooperate and facilitate the best treatment for some of these patients.
Transportation is going to be one of these issues that we're going to come and talk to you about probably in the near future. Our MCOs, I will applaud their work. They're becoming very creative, contracting with some non-traditional type folks to get our members to where they need to go for treatment. Because here's the end result of these types of matters. If we don't have access to our members, we're not able to coordinate care. What happens?
Those drugs.
And they go to the emergency room. And we all know that is a triage care that is the most expensive care to deliver, when we know there are better ways to treat folks. And so that's our job, is to make sure that we're identifying and coordinating the care in the best facility possible that leads to best outcomes. And without access and without knowing that our members are there, it's very hard to do. We're ready to take on that task.
Thank you.
Thank you.
Thanks, Ben. Appreciate it very much. And as our next people are going to get ready, Dr. Gibson and Sarah Doherty from Wonder School, we'll go ahead and just backtrack since we have developed this. We have attained a quorum since Mr. Beeks took the podium. So I'd like to go back and let the vice chair promote on accepting the minutes of the prior meeting on October 16th.
Thank you, Mr. Co-Chair. I move the minutes from October 16th be approved.
Motion on the minutes of October 16th, 2023 be approved. All those in favor say aye.
Aye.
Opposed say no. Minutes are approved. Okay, now our next two presenters, go ahead and make your way up to the podium. Ashley, Sarah.
We're here.
Oh, you're back there. Okay, great. Good to see you. Okay, well, you're on. Whenever, starting to you're up and running there. Okay, first, introduce yourself.
Hi, everyone. Good afternoon. Thank you. My name is Sarah Doherty. I'm on our state partnerships union at Wonder School, and I'm joined by my Ashley Gibson. Yep, nice to be here. Thanks for
Okay,
having us.
raise your right hand. You both swear that testimony you'll give you the truth, the whole truth, nothing but the truth, help you God?
Yep.
Okay, great. All right, so how are we going to do it? You get the floor.
Great. So we're here to talk about Wonder School, which is a childcare technology and services company that works with states to implement innovative childcare solutions that are tailored to the regional needs of the states where we're working. And our approach is to increase the supply of childcare, the number of slots that are available to families, and the number of affordable slots that are available to families by recruiting, training, licensing, and starting small childcare businesses that are primarily women-owned. In addition to starting new programs, we also bring a number of technology tools that we'll discuss that can help provide insight into where care is needed, into where parents are searching for care and unable to find it, into the financial health of childcare programs, as well as making childcare more easily available for families to find from their mobile device. And so we'll go into a little bit of detail just about the company and about the economic case in particular for investing in childcare, and talk about some examples of where we've worked elsewhere in the country and some of the solutions that we think will be a good fit for West Virginia in particular. So the childcare gap in West Virginia, I'm sure, is not surprising. I'm sure many of you have seen this data, but there are about 68,000 children from ages 0 to 5, and and the childcare capacity does not cover all of that. So it leaves a gap of about 38% for families who might need care, meaning they have one or more parents in the workforce and their children are not quite school age yet. So that gap, in addition to being a burden for families, being an economic and educational disadvantage to children, we know that there is a measurable return on investment when money is invested in creating high quality new childcare slots. That's about $13 in ROI for every dollar that's spent on creating new high quality childcare slots, especially for disadvantaged children. In West Virginia, in particular, according to data from the Bipartisan Policy Institute, leaving this current gap unaddressed could lead to a loss of nearly $900 million to $1.4 billion over the next 10 years. That's a combination of productivity, workforce participation, taxes, and a number of other measures that, this is not accounting for what could be gained. This is just what will certainly be lost if the gap is not addressed. Wonder School helps solve for that gap. We are a company that started by working one-on-one, primarily with women who wanted to start a childcare business, but didn't know how to navigate the system. They were overwhelmed by paperwork. And so we started working with them one-on-one to provide business coaching, support, navigating a state licensing system, making sure they're highly qualified, and then helping them market their programs. We've since scaled that to work nationally. We've got state partnerships across the country. We've got nearly 40,000 providers that use our technology tools. And every one of these solutions is tailored to match the state where we're working. But as you can see, we work in a number of states with a similar profile to West Virginia. That's rural, states that are attracting large investments from the private sector and growing in that way, but maybe not the ones you would think of who have the most robust childcare or education system. And the way that we help is through a multi-pronged approach. And I'll let you talk.
Yeah. So when Sarah and I really were looking at the profile of West Virginia and how we could be helpful, is we really wanted to take as holistic of an approach as we could for the state and really laying a foundation that could be built upon over years with different layered solutions. So in addition to creating new childcare capacity through recruiting individuals to become in-home family childcare providers, where we can be intentional where we recruit them, we can be proactive in who we recruit, and the shift work and the non-traditional hours that are needed and the communities that need it the most. We want to establish those new childcare slots. Also want to put in place a one-stop shop for families to find childcare so they can tailor their search based on what they're looking for the age, the type of care, the days, the hours, the affordability. We also want to support existing childcare providers and getting them access to our technology that provides them basic business operations. Childcare providers are really passionate about watching children, but no one is helping them be small business owners. So we will provide that via our technology. And while we're doing all of this, we will also conduct research and do a market analysis to make sure we know where we're filling the gaps, where it still exists, and additional solution layers that we need to add. And on top of all of that, this can also be intertwined for a hybrid model for employer partnerships to be addressed or for employers to directly contract with Wonder School to provide childcare solutions.
We can go into a little bit of detail and sort of any questions about this, but we do have a process that we've used in states across the country. Again, it's tailored to the specific need, the demographics, the geography of the state, but we go out into the field, we hire folks on the ground to help us training, support, and recruitment. And we identify people who are in a good position to start a childcare business. They may be parents who left the workforce because they had young children and it wasn't affordable. They might be retired, second career. A lot of teachers decide to open a program, or grandparents. But wherever we're working, we work to make sure that they are fully licensed, that they're participating in any available state quality programs, that they have tools, business coaching, everything that they need, not just to open, but to be successful and sustainable. If we were to launch these businesses and then step away and they close down, that actually puts the community at more of a disadvantage. The focus on family childcare is to keep the options for families close by, to keep the money in the community, and to more quickly open programs in the areas that are high needs. A center is, the time and expense to open a childcare center is 1 to 2 years, and usually at a minimum $500,000 to $1 million, versus a home-based program can be launched in 6 to 12 months for a fraction of that cost. So per program, we should clarify, I think you're using the word provider, and that may be confusing given the previous presentation. When we say provider, we refer to a childcare program business owner, so a woman who owns, say woman, because 95% of our programs are women owned, who owns a program in their home or an approved facility. It costs about $25,000 per program. They can provide care for 6 to 12 children, depending on their licensure and staffing ratios. And at a minimum, we estimate that that enables 4 family members to return to the workforce. In the upper ends of those ratios, it's much more than that. So that is a very high level summary of what we do and how we do it and what we think would be beneficial to West Virginia. We'd love to share more information based on your questions. So happy to take some of those now.
Thank you for that presentation. We do have 2 after you, but we have probably at least 10 to 12 minutes time for y'all for questions. So it's quite a bit. So if anyone has some questions, please speak up.
Thank you all for being here. I was just curious how you're currently identifying new providers. You talked about being good at recruiting new people. What's the process look like for that now?
So in some of the states where we're working, it looks like going into the community and holding informational sessions. In Michigan, we're running radio ads to get people into the funnel. We do a vetting process ourselves to make sure they're qualified, they have a legitimate interest in doing this, that their home is the right space and wouldn't require significant amount of renovations. And then on top of that, we take them through the official state licensing process. So those are some of the ways. We also work with local childcare agencies like childcare resource and referral agencies to identify people who maybe started an application or submitted for a permit and just dropped off. It's usually because they've become overwhelmed and don't really know how to take the next steps. So we can work with them to get them through the process.
Thank you, Dr. Ken. Tell us a little bit about your single point of entry. Of your, what you all do and how it providers, what's their information into maybe web-based or apps or things along those lines. Can you talk about that a little bit?
Yeah, so all of the above. Our technology is can be utilized on a mobile phone, it can be utilized on a tablet, on a computer, and to Sarah's point, once they're recruited, first and foremost, we want to get them access to the technology. So they're modernized, so they're doing the work. And in conversations we've had in West Virginia, we have had the conversations around if that entry point would be a barrier. If someone wouldn't have access to the technology, wouldn't have access to broadband infrastructure, how we would navigate that. So that is something that we have embedded into the proposal to get access to those devices, and then also Wi-Fi, hotspots, things like that, so they can be successful. Because not only is it successful in integrating them into a cohort of other providers to have peers to bounce ideas off of, it's also important for them in communicating with parents, being able to maintain full enrollment. And as a small business owner, It's really important that they stay fully enrolled, so that way they collect every dollar that's owed to them, because it keeps the affordability down and makes sure that they remain a stable childcare provider in the community.
So, although as a state, we are on the path to improved connectivity throughout, there still are significant limitations in many areas. You do not see that as a hindrance whatsoever going forward?
Nope, we do not. We would utilize sort of the cell phone hotspots, and that would be a portion of it that would be embedded in the state proposal overall. And then as connectivity would improve, we could switch how that is operated, but we don't. We've done this work in very rural areas in New Mexico and Nevada and other states that have had some of these same aspirations that just hadn't been implemented yet. And so we feel confident that that would not be a barrier for us.
That's good to hear. Thank you. Any further questions? None. Thank you all very much. Charlie gets ready here. The next presenter can be Hallie Mason, Executive Director of West Virginia Dental Health Association. It's Dr. Dan Joseph, Medicaid Dental.
Thank you. Thank you, Chairman Maroney and Chairwoman Summers, for having us. I'm Hallie Mason, Executive Director of the West Virginia Dental Association. With me today is Dr. Dan Joseph, who will be in the room in a second, and Dr. Mike Medevich. If you'd stand, Dr. Medevich. Dr. Medevich is a retired dentist from the Wheeling area, and I'd like to note he's also running for the National President of the American Dental Association. So we would love to have him represent West Virginia, not just in our state, but nationally. Thank you for coming, Dr. Medevich. The members of the West Virginia Dental Association appreciate the opportunity for us to highlight some important workforce and policy issues for you today. But due to limited time, I'm going to quickly go through some of the slides. However, I believe you do have them in your handout. So there's more detail in your handout, and would be happy to talk about that after the meeting with you. West Virginia has over 850 licensed practicing dentists. This number is similar to 10 years ago in 2013, but I would like to note on this chart that West Virginia defies the national dentist demographic. So here's the national. In West Virginia, we have a significant number of dentists, 65 and over, who remain actively licensed. Many of these are dentists who have retired from private practice, but are now working in community clinics. I've spoken to a few dentists who actually drive a few hours, stay for 3 days in an area that desperately needs a dentist, and then drive home for the weekend. Also wanted to share that of West Virginia's new dentists, so dentists who've been practicing for less than 10 years, we have a 3.6% net migration out of West Virginia. A majority of these just went over the border to Ohio, Virginia, and Pennsylvania. Yes, of course, some went to North Carolina and Florida, but that's not a majority. West Virginia is similar to other southern states where the number of dentists per 100,000 residents is less than 50. However, some great news. 83% of dentists practicing in West Virginia are graduates of the West Virginia School of Dentistry. There are 14 states right now that do not have a dental school. So our citizens are very blessed to have a school training dentists here. Clearly, the return on investment for the state is very high, as many of the graduates stay in West Virginia. I did want to point out that in last year's freshman dental class, 31 of the 48 first-year students are from West Virginia, and these are the counties where they hail from. And in this year's fall of 2023 freshman class, half of the class is from West Virginia. So clearly, we have native West Virginia dentists in the pipeline being trained in Morgantown. We just need to figure out how to keep them here, which is one of the reasons I'm speaking to you today. A little bit of background. I've been around Medicaid and the legislature for a long time, but until taking this position, I clearly didn't understand there are two distinct dental programs in West Virginia Medicaid. First, on the right side of the screen, there's the fee-for-service traditional Medicaid program. That program serves a distinct population, so CHIP waiver program and foster care kids. Please know that nationally, that program, the fee-for-service, is the highest in West Virginia. We have the second highest reimbursement for children and the fourth highest reimbursement for adults. However, it's only 5% of the whole Medicaid population. So the main population, the 95%, is under adult dental HMO Medicaid. For those who have not been in the legislature very long, in 2020, Senate Bill 648 provided preventative and restorative dental coverage for adults through Medicaid. There's a $1,000 coverage limit per calendar year, and remaining balances are not carried over. It was funded by a concurrent HMO tax, but I see the finance chairman here. He knows very well the HMO tax was not solely for the dental benefit. And I'm afraid there's a managed care data void, so I can't compare reimbursement rates for the fee-for-service with the HMO program because that is not anything that I'm able to access, and neither is the American Dental Association. As you can see, this is an interim report from May. So I've circled the 5% fee-for-service program is on the end, and you can see it's 5% of probably the full population served, as well as 5% of the cost. During the debate over passing the adult dental Medicaid bill, there was concern that there needed to be control of the cost of the program in fear of pent-up demand. Now, many members who are here were part of that debate, and so they can speak to other reasons as well. And that's why I believe the $1,000 limit was placed on the benefit. However, the West Virginia Dental Association contends that this has actually had a negative effect on the program in overly burdensome restrictions on patient services and low financial viability for dentists. Skip through those slides. So the West Virginia Dental Association respectfully asked the legislature, we are seeking flexibility with, or an increase to, or an elimination of the $1,000 statutory limit on adult dental Medicaid benefits. Now, switching gears, the School of Dentistry Dean, Dr. Pachuta, oh, I'm sorry, I forgot about this slide. So in your packet, there's some examples of other states and how they provide flexibility with that limit. Also, I recognize that Medicare is very separate and members of Medicare pay for their benefits. But as you'll see here, there's a $3,500 annual limit for Medicare. And so people are used to talking about a $1,000 limit with insurance. It's not always $1,000. It can be higher. Of course, it can be lower as well. Switching gears, WVU School of Dentistry Dean Dr. Pachuta was unable to join us today to provide an update on the facility and modernization initiative at the dental school. However, in your packet are a few slides. And just, I believe more information will be coming to you about this during the legislative session. But if you have specific questions, representatives from WVU are here this weekend and they can answer them. With this, I'd like to introduce Dr. Dan Joseph. He's a Wheeling orthodontist to share some additional information.
Thank you, Alice. Thank you, everyone. On behalf of the dental patients, orthodontic patients throughout the state, I'm going to be asking for your help. Fairly recent phenomenon has occurred with do-it-yourself orthodontics and the use of clear aligners that are shipped directly from an out-of-state manufacturer to patients. And this is done without any kind of in-person examination, without x-rays, I was offered a position to work for one of these companies, so I know how it operates. So there's no real diagnosis. So someone is sent a little kit, they take a little impression of the teeth without anybody checking to see what the oral health care, the oral health of that individual is. As a result, we've seen harm to patients. We've seen teeth that are pushed through the bone. We have seen gums stripped off their teeth. We've seen a number of different things that have occurred, I and some of my colleagues. For me to properly treat a patient, I need to formulate a diagnosis. It requires hard and soft tissue examination, appropriate x-rays, photographs, and needed measurements. Oftentimes, I have to refer the patient back to the dentist before I even consider doing any kind of orthodontic treatment on them. I've told patients that have underlying conditions, oftentimes, go back to the dentist, get checked. Twice last week, I had patients that I said, you just aren't a good candidate for doing treatment. The do-it-yourself advertisement that you see on TV and on the internet and so forth, make it really appealing to get your teeth straightened and what an incentive with them to see a practitioner in the process. Unfortunately, it doesn't always work out well, as I indicated. I'm presently treating a lawyer, the one physician, and a policeman who basically have failed in their treatment by going that route. Fortunately, unlike some of the others, there was no real damage created to them, except for the fact that they lost their money. And when they go back to try to get the money, they failed in all three cases, despite the fact they say there's money back guarantee. One of the issues that they've run into is that they had to prove that they have all the little clear plastic aligners before they would give your money back. If you don't get it, you don't get your money back. And if you do get your money back, you have to sign a non-disclosure agreement about what happens. So you won't hear a lot of negatives out there because someone's had to sign an NDA to get their money back. So what happens is I'm basically reaching out to you folks to help me and my colleagues help the patients of West Virginia. Well, at this time, we don't have any legislation written. I might be asking for some help. Recently, a bill passed through the state of Nevada through the legislature that would require an in-person initial exam. Now, most orthodontists don't charge for an in-person initial exam, so don't think that they want the money because most of those are free. That's our screening that says, yes, you're not a candidate. That is critical. We have to have an in-person exam up front. Teledentistry, telemedicine are wonderful. I'm very supportive, done great things for the state and the citizens of West Virginia. What's not great is when you start treatment without a diagnosis, and you cannot diagnose by a photograph or by someone takes a little impression of their own teeth and ships it off to somebody without being able to check the hard and soft tissues before they do that, any kind of treatment. It's just a loophole in the law right now. It allows this to be done. So yes, we don't want to eliminate telemedicine. We don't eliminate teledentistry. It does some wonderful things for people, but we do need to eliminate that loophole that allows an out-of-state company to come in here and treat people. And those people, by the way, the citizens that are getting that treatment done, the patients, do not know who the so-called practitioner is. They have to tie a name in order to produce that product and send it to West Virginia. But ask any of the patients, who is the doctor that's treating them? They've never seen him and they don't know who it is and they can't find out. So basically the issue is, I'm looking forward to working with some folks in this room. We need to do something to help these folks because if we don't do it, no one else is going to help these people. And it's every day we're having more. Anybody that knows any orthodontists can ask the question, have you seen any of these and what are the results? So that's all I have for today. Thank you so much. Appreciate you listening to me.
Thank you, Dr. Joseph. Doctor, step back up to podium, ask a few questions.
Sure.
And before we start, I just wanted to swear you and engage the presentation. If we can just raise your right hand, and swear any answer to any testimony you give will be truthful, please come with truth. Senator from Ohio.
Thank you, Mr. Chairman. Not really a question, more of a statement. Dr. Joseph said he's from Wheeling, so I can tell you all personal experience. You should all this. Tremendously, and I know his passion on this topic. We've talked many times, and I know that it's genuine. So I just want to thank you for being here today. I know this is a area of genuine concern for you and look forward to working with you on it. Thank you for being here.
Okay, thanks so much.
Absolutely.
Any further questions? Thank you, Doug.
Thank you so much.
Holly Benson, any questions for Mason here? I'm sorry.
And you may or may not know the answers to this. How many endodontists, periodontists, and all of these specialties do we have in the state?
Good question. I'm sorry, I can't answer that off the top of my head, but I can get the information for the
I think
committee.
those numbers are very low. I think at one point in time, we only had 2 periods here. Maybe it may even be 1 now. But I would like to have that information if somebody does have it.
Dr. Medevich, do you know?
I would say all the specialties, I can't speak for ortho, but all the other specialties, there's 20 or less in the entire state of each specialty. Some of them even lower.
Doug, let's get up to the podium and if you're going to do some, thank you. Just before you finish, just introduce yourselves in case anyone's listening, have to know who we're dealing with.
Sure. I'm Dr. Mike Medovic. I practiced in Wheeling for 38 years, general practitioner, now on the board of the American Dental
Go ahead and
Association.
continue. Go ahead and continue.
So again, specialties, dentistry actually is doing things right. When you think about it, we are very general practice oriented. So round figure, 75% of dentists are general practitioners, 25% are specialists. The medical system is the entire opposite of that. Almost all physicians are specialists of one type or another. You usually don't have a patient ask you, I can't get in to see an orthopedic surgeon. Can't find a family practitioner. I can't find a general practitioner. So in dentistry, our model is actually working much better. And that's not to put down the physicians because they're doing yeoman's work with the system that they have. But dentistry is doing it right. Yet I can get my patients in to see a specialist within a day or two. Sometimes that day it's an emergency. Try doing that. I have a neurosurgery issue and I'm not going to have my surgery until December the 19th. So the point I'm making, and it's due to 38 years of practice dentistry, it's cervical stenosis. But anyway, we have a much more efficient system. Any other questions?
Go check.
Did you say you thought there were 20 or less in those specialties?
Yes,
Would that include orthodontics?
I would think.
No, the number of practicing orthodontists, may I speak? I got up there. Didn't know anything about orthodontics. Okay. No, the issue as far as orthodontists go, no. We have actively practicing somewhere less than 40. Total number is somewhere in excess of 50 if you get all that are in West Virginia.
So 50 orthodontists for 1.7 million people. But we're considering changing the law because we think it's a loophole, which I'll say it's actually intentional. That people, if they so choose, can order Invisalign or whatever the other companies are online. But you think we should change it so they have to see?
Just all they need is one exam to be sure they're safe to do it. That's all. Rest of it doesn't matter. They should have an in-person examination just to sign on it. As far as the number of orthodontists that are in the state of West Virginia, because of the rural nature of our state, that's not unusual for a state like ours to have that few.
Any questions? I have one for Mason. I was part of that Medicaid MTO tax that bill that $1,000 a couple years ago. How much money does the MTO tax bring in? Because that bill was like it was a passed bill, but it was contingent. It did not go into effect. It was contingent upon the passage. And when we passed the other bill, the MTO tax, it was contingent upon CMS accepting it, money coming back. The federal government, so it was federal money coming in. How much federal money came in from that tax in general?
I've reached out to the state tax department and asked them that question, and I was told it's proprietary information because it's based on HMO profits perhaps, so I don't know the answer. But I was assured by an individual who works with that there's a steady stream of revenue.
So and 10 million went to the dental.
Right,
So
so
that bill that we passed in 2020, 10 million of that lump sum of that MGO tax
it should.
went to this dental program.
So if you look at the fiscal note, it suggested that perhaps 20% of patients would utilize. If that was the case, that would be 8 million of general revenue and the rest would have been federal. However, 20% of Medicaid patients are not utilizing it. It's more like in the double digits. So if we look back at the fiscal note, there's a strong chance that general revenue for this service is way less than you expect.
Thank you. Any other questions? Sure.
Thank you, Hallie, for being here. How much does a set of dentures cost?
That's going to vary from office to office, so if you don't like. Been retired for 5 years, so I'm going to say, $4,000.
Okay, so $1,000 for a person that utilizes this can't get dentures. So seems like a lot of our population has teeth pulled and has no teeth and needs teeth to eat and get a job and all these other kind of things. So we're not really helping those people that need dentures.
Exactly.
And you have.
But it's $1,000 per year, but you can't aggregate it. Correct.
And you can't break up a denture between years, you know, you have to.
Exactly.
do it together.
Right.
So otherwise it would function. That's why some of the states exclude dentures from that.
All right, thank you.
And of course, having dentures is imperative to being able to chew and eat various healthier kinds of food. So
And get a job.
Thank you.
Well, I'll just to make a comment, someone else is raising their hands. The working in the hospital, reading films for ERs or any nurses working in the ER before, you see, probably across, my guess would be across this state, it would take within a month, probably spend $10 million on CT scans of the face after hours from the ER for people with facial cellulitis that's due to poor dentition. So just from a standpoint of spending money to make money, but not to mention that the money you're spending is going into the community, we spent further, but we're paying. Medicaid is paying. They pay for those. When you have facial cellulitis to go to the ERs, we're paying those bills, and there's a ton of them, and it's all because of bad teeth. That's you got to think 2 steps ahead sometimes when it comes to spending money. That's my opinion. I've done it for 25 years. I see it every day. So, any further questions?
Another point, Dan talked about diagnosis, and examination. Oral cancer is a major factor, especially with our heavy use of cigarettes, smokeless tobacco, vaping. So to make sure patients do not have any cancerous lesions.
All right. I think that's it. Thanks to all 3 of the presenters. This last but not least, John Antal, Director of Clinical Services, Orchard Park Hospital. Jacqueline Knight, CEO of Orchard Park Hospital. And give us a little update on this hospital. It's does one of those things that just reopened not too long ago. All right. You all right? Just identify yourself for the one at a time then?
Yeah, hi, everyone. Thank you for having us. I'm Jacqueline Knight. I'm the CEO of Orchard Park Hospital and also the Children's Home of Wheeling, which is a residential treatment facility here in Philly. But we're here today to talk about the hospital, and we also have our clinical director.
Yes, my name is John Antal, and I'm the Director of Clinical Services at Orchard Park Hospital.
Thank you all for being here. Look forward to the update. You just want to raise your right hand. You swear that your testimony and your presentation will be the truth, the whole truth, nothing but the truth. So help you out?
Yeah.
Okay, thank you for being here. Take the floor to anywhere you want to.
Yeah, absolutely. Well, just to kick off, so we are in acute care inpatient hospital. We serve children ages 5 through 18 in the state of West Virginia. We have a state-of-the-art facility. We're handicap accessible. It's a 30-bed facility, and we just reopened at the end of September. We saw our first patients on September 25th of this year. Our hospital was previously in operation under the OBMC main campus, Robert C. Byrd Center, as it was known. So the Children's Home of Wheeling actually acquired this building and really worked diligently over the past few years to get this service back open. It's been a major gap for us locally here in Wheeling and the upper panhandle of the state, as well as, we serve patients from across the state. So really a major loss of services, something that we were impacted with our residential facility as well, our kids needing this level of care. So our board of directors really was committed to doing something that would improve, access for kids in our community. And that's where this project came about. We did put in, so one of the things that kind of gave us an extended timeline for opening, we had to install a brand new commercial kitchen into this facility. So previously when it was operating under OBMC, they utilized the main campus's kitchen. So that was something that took us quite a bit of time due to the pandemic and all things supply chain issues. But it is, as I said, state-of-the-art facility. We also had to do some other upgrades. Everything in our facility is anti-ligature. So again, we're serving these very high acuity patients who are suicidal, actively self-harming, maybe homicidal, other things. So we want to make sure that we have the safest facility and that we're providing the best care possible. So we also include, some different recreation areas for patients. So it's not just you're in a sterile environment all the time, getting therapy. They have to be active. They have to do some other things. So now I will officially hand it over to John. I keep forgetting some of our slides here. So.
Okay. Anyway, this is a very, very needed facility in the state of West Virginia. We work with, like as Jackie said, children ages 5 through 18, and we work with children that definitely need our services if they are suicidal, homicidal, actively. Okay, and let me just talk about the admission criteria. The way that the kids are admitted to our facility, they would have to go through the emergency room first. And we do not have them walk in because they have to be medically cleared. Because when we work with children, we want to make sure that they are healthy medically. If they have, if they've ingested any kind of substances, we are not a medical hospital. We are a psychiatric hospital. And we are not affiliated with any other medical hospitals or universities or anything of that nature. So when we work with the kids, we want to make sure we give them the treatment that we can behavioral. So when they come into our building, they're initially they come through the intake department. So the emergency room would contact our intake department. And at that time, the intake person would take the information down. They would discuss it with our attending physician, and then it would go doc to doc from the attending physician to the ER. And they would discuss whether this child is appropriate for our inpatient services or not. And at that point, once they are approved for our services, they would enter our facility. They would go through the intake process. Once they get there, the parent or the guardian would have to accompany them once they get to our facility. And once they get there, we get the proper information that is needed. And then they would have a psychiatric evaluation by the attending psychiatrist. They would have a nursing assessment by the RN on duty. We would have a biopsychosocial assessment by the clinical therapist, and history and physical by a physician. And once they are on our unit, the average length of stay is anywhere from 7 to 10 days. And we do many, many different types of treatment with these children. We do medication management, individual, family, cognitive group therapy sessions. We have master's level licensed clinical therapists We have, excuse me, activity therapists that engage in art, music, exercise, and recreational activities. We also have education groups, nursing groups, social skills groups. And in the mornings, we have goals group. Now, the mental health technicians are the folks who work around the clock with kids themselves. And whenever a child is admitted to the unit, we go through a daily, basically, in the morning, they do their daily goals. They select 2 to 3 different goals they are setting as measurable. And then throughout the day, they work on those goals in order to meet them for wrap-up group at the end of the day. Throughout the day, they attend our cognitive groups, our other specialized groups that we have, and they're seen by a psychiatrist on a daily basis or a physician extender who may be a nurse practitioner. Now, they are seen 7 days a week by the physician or the physician extender. And we also do groups, especially cognitive groups, as well as activity groups, 7 days per week. We also do individual and family sessions because we want to be able to involve the family, because at this point in their therapy, the family involvement or the guardian involvement is very, very important. And we also create treatment plans for them. Excuse me, this is my voice. We also create treatment plans with them within the first 24 hours of them entering our hospital. And then we meet twice daily or twice weekly with the psychiatrists in order to do the treatment team meetings themselves. And during the treatment team, we have the treatment team that's present. We talk about their issues, we talk about the diagnoses, we talk about treatment strategies and the needed issues that they're working on. And we also have a case manager who begins discharge planning upon admission. So when they're discharged, we also keep in touch with the schools. We also keep in touch with their therapists, their outpatient therapists, and we set them up for outpatient psychiatric medication. And one of the issues I know was that when schools would refer patients, they would talk with the parents, and then the parents would take the child to the emergency room, and then some of the schools would not even know if the child actually received treatment at different hospitals. But one thing we want to do is have the guardian or the parent sign a release of information so we can keep in contact with the schools, because a lot of times the kids are getting bullied at school. A lot of times they have poor access to needs. A lot of times they have a difficult time interacting with other kids in school. And at that point, they're feeling suicidal. They may be isolating at home, or they might be self-harming at home. So we want to make sure that we're working with these children to the best of our ability, and to make sure that the schools are informed that the child is receiving treatment. And upon discharge, we want to make sure that we have a good plan for them to return to the schools, as well as to return to the family, and as well as getting follow-up for medication management and for outpatient therapy.
And just to add, that was one of the reasons why it was so important for us to bring the service back to this area. When kids are getting treatment, 4+ hours away from their home, having the family involvement is very hard. Having that connection to the schools is very hard. So while I mentioned earlier, we are seeing kids from, further away in the state. That's just because of the overall limited access for this type of care. But we're also having a lot of our local kids that were previously, sitting at ERs for days, 4+ days on some occasions that we've heard, or having to go, that 4 or 5 hour away mark. So it's really beneficial to the community to have this nearby.
Thank you all. Thank you all very much. We're getting near the end of time. We have 3 or 4 minutes. If anyone has questions? Elliot?
Yes, thank you. Thank you for bringing. My question is, they're at the ER. What's their form of transportation to your facility?
So the ambulance does bring them to our facility. That way there's
So
no.
can they be restrained or can they, will they be, pharmaceutically, relaxed?
That would probably depend on the severity of the case. I will say of the patients that we have seen since opening, we have not had any that have been that severe, at the time of admission. They've, been treated or somewhat, managed in that, emergency room situation.
And if, who pays for that?
The insurance companies.
Huh?
The insurance companies, I would guess. It's not something that our facility is not part of our total cost. Yes. The reason why we have them transported by ambulance is just to ensure that they are still medically safe. If they were to be discharged from that emergency room and maybe transported by their parents, we don't know what they may have had access to in the ride from ER to our facility that maybe would impair their physical health. And, as we were talking, we can't treat them medically. We're not designed for that. We have access to that.
So would Medicaid cover that cost?
I believe so. But it's not through our rate. So that's not something, I was gonna say, I can't answer that because that's outside of our scope. I believe so, just in talking to
Delegate, another question. Which district you from?
District 4.
Oh, Delegate District 4. Thank you.
Thank you. Thank you, Mr. Chair. Thank you both for being here. I was lucky enough to be at your grand opening. The facility is wonderful. We appreciate your commitment to the community. So you've been in operation about 6 weeks. What is your average kind of occupancy rate of the beds?
So I will say we started off small. We only have one wing open so far. So as we kind of talked about, and I think it's in the information we gave you too, we are designed with a child wing, an adolescent wing, and then a 4-bed special care wing in the back. Right now, we're only operating one of those. Just as we ramped up staffing, kind of got all that ready to go. We are very close to having enough personnel to open our second unit. So that's our goal for the next month, I would say, is to get both units running. We had an average of about 5 patients per day for the first month or so. The last week, we've really seen that increase. So I think we're up to 8 now. We have served in total, I just looked at it, John, right before, so I had the updated number. So 26 patients, and the average has been 7 days.
And does that cover, are you turning away referrals?
Yes, so I will say we have denied some referrals. When we initially started and we're still working on the staffing model and getting enough folks in the door, we were keeping it a limited age range. With only having the 1 unit open, we did not want to have, a 7-year-old, which our very first patient was 7 years old, in the same facility or same hallway with a 16-year-old. So we did deny some due to age, which is why it's really critical that we get the second unit open ASAP so that we can serve both age groups that we're seeing. And then just some that were not appropriate for the level that they were being referred and denied for different reasons on that end too.
Thank you all for that update. Appreciate it very much. That's going to be it. For those of you going to a hockey game, the bus is out front on the parking lot side, Market Street side, where the black fence is, where a lot of people live. If you go out the other side on Main Street side, it's about a 4-minute walk probably. It's not far, it's right down to the road. And with that being said, I look to Vice Chair for motion on adjournment.
And they said the bus is going from here to the arena and then from the arena to Ogilvy. So if you're not getting off the arena, just stay on the ticket to Ogilvy. I move we adjourn.
Motion on adjournment. All those in favor, say aye.
Aye.
We're adjourned.
Hello.